Hello, this is Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club. This week our episode is focused on the recent ASCO GU Symposium. We start with a roundtable discussion of the key papers with some very insightful guests. Eva Segelov and Craig Underhill are joined by Phillip Parente and Carmel Pezaro. Welcome. Eva also catches up with Michael Hofman to chat about his Lutetium PSMA trial. We hope you enjoyed today's entertaining and informative episode. As ever, the links to all of the papers discussed today are available in the notes. For the latest oncology news and podcast updates, subscribe to the Oncology newsletter for free on oncologynews.com.au. This is Rachel Babin, and this is the Oncology Podcast.
G'day. Now, I've got a question for you. Which is the best oncology specialty to be in at the moment? Well, let's have a look at what happened at the recent ASCO GU meeting. Hot on the heels of ASCO GI, and don't forget our special podcast on that, and World Lung, which features actually a musical interlude by a plenary presenter. We now have two fantastic guests with us to chew the fat about ASCO GU. Now, these two people are on opposite sides of the world, although not that long ago, they were in the same office. I'm talking about none other than Phillip Parente, Head of Oncology at Box Hill Hospital here in Melbourne. Hi, Phil.
Hello, Eva and Craig.
And our wonderful friend, Carmel Pezaro. So Carmel moved across the ditch, but it wasn't far enough. She's had to leave us to the other side of the world, the heart of the empire, now in Sheffield in the UK. So lovely to have gender equity on this podcast, me and Carmel versus Craig and Phil. And lovely to have you with us. Hi, Carmel.
Hi, thank you so much for having me.
Isn't this great? And it's not a mantle.
It's not a mantle. It's so much fun on Twitter. When you spot a mantle, you just alert people and goes viral.
So, Eva, I want to answer to your question. So, how many NEJM and Lancet papers come out of ASCO GI versus ASCO GU?
Well, that's an interesting question. We have got a special interview with the author of one of the Lancet papers, none other than Michael Hofman, with his Lutetium PSMA trial. So, yes, maybe you're winning. Let's see. So, some years ago, when I was a young oncologist, many years ago actually, urothelial cancer, we didn't even know what that was. And now it's hot topic. Phil.
Sure is, Eva. It's really moved into the area of a very treatable cancer. And the reason why, because it's been responsive to immunotherapy. And also there's been targets that have been found, which are now being targeted. And as we know, targeted therapy have usually superior response rates with lower toxicity. And this has been really the mainstay of the trials. There's been an issue with urothelial cancer trials in the past that were difficult to recruit, but the current publications at ASCO GU have really overcome that hurdle in the past to really do rapid recruitment, to complete the trials, to get really quality data coming out.
Fantastic. So that sounds like a good segue to get straight into it, Phil, so that we're going to touch on immuno-oncology first in the urothelial cancer space. So Checkmate 274, data which supports adjuvant nivolumab as a new standard after surgery in muscle-invasive urothelial carcinoma. Phil, do you want to outline this abstract 391?
Yes, Craig. So this was another one of the Checkmate trials, so 274 trial, which randomized patients to adjuvant nivolumab versus placebo post a cystectomy. Patients may or may not have had neoadjuvant chemotherapy. That wasn't a complete 100% eligibility into the trial, and 60% of them had neoadjuvant chemotherapy, while 40% did not. And then they had cystectomy. Then they were randomized to nivolumab at standard doses for for a year versus placebo. They were also stratified for PD-L1. 40% were greater than 1% PD-L1, while the remainder were 0%. And the trial rapidly recruited. So as I stated before, there were issues with neoadjuvant and adjuvant urothelial trials. They were difficult to recruit and difficult to get mature data. This recruited very quickly. Obviously, immunotherapy is very attractive. Patients wanted to be randomized, and the outcomes have been very clear-cut.
So, Phil, tell us about the main outcomes from the study.
The main outcomes were disease-free survival, which showed a big difference between nivolumab and placebo, 21 months versus 10 months, with a significant p-value and a hazard ratio of 0.7. And when the patients were stratified with a PD-L1 status of greater than 1%, the difference was even greater, with a hazard ratio of 0.53. That was the main result of the trial. And then there were secondary endpoints as well favouring nivolumab.
So no overall survival advantage. So it's probably a bit of a stretch to call it a new standard here.
No, I wouldn't agree with that, actually. The data is still immature. With more follow-up, there most likely will be an overall survival advantage. That was the opinion of the discussants and the general feeling amongst the ASCO GU oncologists at the conference, that more time, the overall survival benefit will be seen. This trial can actually be put into practice today. We can actually have that data. Nivolumab, we know, is safe. We know immunotherapy is safe in bladder cancer. So it's not out of the realms of possibility that if patients wanted to pay for this drug in the adjuvant setting, that they could have this prescribed. I think it's a real world treatment option as of today.
Carmel, do you agree?
I do. There are a couple of things I found really interesting, though. One of the things is we are committing people to 2 weekly treatment for a year, maybe 4 weekly if we're prepared to do the equivalents that we've done in other kind of tumour settings. But the other thing is I was fascinated by the grade 3 or 4 treatment-related adverse events, which were thought to be 18% in the treatment arm, but actually also over 7% in the placebo arm, which really makes me think we're not very good at judging treatment-related adverse events, but also for people who have non-metastatic disease, that's not an insignificant burden of both toxicity and potentially cost and treatments.
Okay. Well, I think we've probably created another ADURA EGFR mutated lung cancer controversy by accepting progression-free survival as an endpoint in an adjuvant study.
I think, Craig, you just want to do another wrap.
No, not at all. Phil, the next one we wanted to cover was a new molecule in urothelial carcinoma. I'm not even sure that I can say this.
Enfortumab vedotin.
Thank you for cutting in there.
Sorry.
Tell us about the study, Phil.
So this was a simultaneous New England Journal of Medicine publication at the time of the presentation. So the premise of the study, enfortumab is a monoclonal antibody against Nectin-4, which is seen on urothelial carcinomas as a target. So this monoclonal antibody targets Nectin-4, but the monoclonal antibody is a carrier for chemotherapy, which is monomethylene arestinine, which I'm sure I pronounced it incorrectly, but it's a carrier, and that chemotherapy will go to the bladder tumour by binding onto Nectin-4, causing cytotoxic chemotherapy and cellular death. So that's the science behind it. We know that in bladder cancer, that post cisplatin-based chemotherapy and after immunotherapy, really treatment options are exceptionally poor. You can choose a taxane, you can choose vincristine or vinca alkaloid, but response rates are less than 10% and heavily toxic. These patients tend to be of poorer performance status and older by the time they hit third-line therapy. And so the phase 2 study showed good safety signals, and then it was randomized to a phase 3. Where patients who had to have prior cisplatin-based chemotherapy, prior immunotherapy, were then randomized onto enfortumab vedotin versus dealer's choice chemotherapy of docetaxel, paclitaxel, or venflunanine, which is standard of care overseas but not in Australia. And the main endpoints was overall survival, which showed a significant benefit of enfortumab over that of chemotherapy of 12.88 months versus 8.97 months, with a hazard ratio of 0.70. But more importantly, it was the toxicity. the patients had quite marked chemotherapy toxicity, while Infidotin had unusual toxicities, but really grade 1 or 2, with rash, peripheral neuropathy, and there was a third of hypoglycemia. And the response rates, the objective response rates, were quite outstanding, 41% versus 18%. And if you look at stable disease, partial response, and complete response, 90% of patients were in that category. There was only 9% of progressors, leading to a very impressive waterfall plot.
And an overall survival advantage?
Of, as I said, 12.9, 13 months versus 9 months, if you round it off.
So it's, as you mentioned, a simultaneous publication in the New England Journal. It's the first time that a drug's been shown to have a survival advantage in the second-line setting in urothelial cancer. So third line in urothelial cancer. I think first time it's shown a survival advantage second line as well. I don't think there's been anything after first line. So we'll be watching this space. Carmel, any comment on this one?
I think this is an amazing publication, beautiful study, and actually really important data. Finally, the community can pull together, behind a very realistic third-line treatment, whereas up till this point, we've really been lost with practice that's really mostly anecdote-based. So it's brilliant data.
And Eva, we're seeing the antibody-drug conjugates in lots of tumours. So, again, interesting area.
Yes, I think that's the next wave coming through and really has the ability to really target and deliver specific drugs to specific tumours. Just for our listeners, if you hear a sort of a groaning or moaning in the background, I just want to reassure you, no one is being murdered, but Phil Parente, self-confessed, cannot sit still on his swivel chair, no matter how many times we've told him. He's one of those guys that's always on the move.
All right. So, Eva, let's change tack. And I think you're going to ask Carmel about some of the prostate cancer publications this meeting.
Great. So, Carmel, lovely to have your perspective. We won't ask you about the Lutetium PSMA trial because we have our exclusive interview. Actually, not so exclusive. I think he's been on Twitter 24/7, every webinar, but good on him, Michael Hofman coming up. But let's talk about Titan and the drug apalutamide.
Yep. So I think for me, other than Lutetium PSMA, it was a lot of value add at ASCO GU this year. Titan was a phase 3 study, which we'd already heard about, but these were the updated survival results. Just to remind everyone, apalutamide, one of the hormone targeting treatments that we can use up front for men who have recently been diagnosed with hormone-sensitive prostate cancer. The Titan study was a phase 3 study, 1-to-1 randomization between apalutamide or placebo. This part of the information was really telling us about the overall survival with a bit more follow-up. So 44 months of median follow-up in this abstract, and the overall survival still not reached as a median for the apalutamide group compared to 52 months in the placebo group. Just over 200 patients crossed over to apalutamide when the study unblinded, when the primary radiographic progression-free survival data had come through. I don't think that makes a huge difference in terms of the survival data, and they did try and analyze with reference to that. Quality of life similar in both groups. And the other interesting thing I thought was actually information about time to castration resistance. Just a reminder for all of us that the old style of androgen deprivation therapy on its own, median time to castration resistance of just under a year. So a good reminder that if we don't add something else in, that's about the time frame we're looking at. Perhaps we've been a bit overly generous in the past with our estimates.
Thank you very much. Anything else exciting in the prostate world?
Yep. So there was also a real value add, I think, coming out of the PROfound trial. There were 2 abstracts. One of them was looking at the gene by gene analysis of olaparib in men who had one of the mutations of interest for HR repair defects. So We know that olaparib improved radiographic progression-free survival compared to placebo in the overall population, but there was an abstract presented by Prof. De Bono which showed that the anti-tumour activity was definitely highest in the BRCA alteration population, much less significant in the other alteration groups, although of course the numbers were really small in some of those much less common defect groups. And there was a second abstract presented by Kim Chi looking at the concordance of tissue compared to circulating tumour DNA, and really reassuring for those of us who struggle to get tissue from our patients, which I think is most of the real world other than some real ivory tower centres, but really high concordance between the tumour tissue and circulating tumour DNA, which I think really suggests that there's a way forward in terms of using that very easy blood sample rather than trying to get tissue from patients.
Thanks, Carmel. That's a plug for our upcoming episode on liquid biopsy or ctDNA. So watch out for that. Carmel, is there any OS data, and when would we expect that? We've seen in other tumour types, most recently in pancreas cancer, where the DFS benefit did not translate to an OS benefit?
Yeah, so as part of Prof. De Bono's abstract, there were some overall survival data presented, and there was definitely a benefit in the BRCA alteration group. So if you look at the sort of 160 odd patients with BRCA alterations, there was a hazard ratio of 0.63 for olaparib compared to placebo in that group.
Great, thank you very much. I think, Craig, it's back to you.
And one of the other interesting things for me was in the P13K AKT pathway data with the combination of ipatercetab plus abiraterone. Did you want to just tell us quickly about that one?
Yeah, so the iPotential 150 trial, again, this was a bit of a value add. We've heard about the trial before, but there was some biomarker analysis presented. I'm going to be very honest, I struggle a bit with these data, just that I find the benefit a little underwhelming, and the toxicity is definitely added when you add a second drug. They looked at PTEN loss by IHC and looked at if you set the cut point differently, and it didn't really change the benefit of adding the ipatasertib. They also looked at next-gen sequencing and saw that if you had genomic alterations in PI3 kinase or AKT or PTEN, there was definitely, again, benefit compared to if you had sort of wild type without genomic alterations to the addition of ipatasertib to the abiraterone. But again, I would throw to Phil because I confess I'm a bit underwhelmed by this combination. I can't see myself using it.
I would agree with Carmel. We've been involved in that clinical trial, and I found the toxicity experience. We knew the patients who went on placebo. The combination therapy was far more toxic than single agent. And if there isn't an overall survival advantage, then why put the patients through it?
And what was the name of the drug again, Phil?
It is called ipatercetab.
I think Carmel wins. Carmel, can you teach everyone how to say it properly, please?
Well, see, you all get my New Zealand accent coming through. Ipatasertib is my version.
Oh, I say abatasertib.
I just call it the drug of the hypertension trial.
So, Carmel, just back to Titan for briefly and the apalutamide. So are you using that in the UK? Because in Australia, we don't have apalutamide or abiraterone available on the reimbursed system, the PBS, for this indication.
We don't either. We have no access to apalutamide at all. We have upfront, at the moment, with the coronavirus restrictions, we have access to upfront enzalutamide, or if the patient's not eligible for enzalutamide, we can offer abiraterone. So I think we're quite similar in that respect.
Those COVID changes expected to stay, surely they won't revert to more cumbersome practices.
I am unfortunately not in a position of knowing what's being discussed at higher levels. I wish I was, but I also can't imagine completely taking it away, particularly because the uptake with men has been very significant. So I would say that at the moment, a majority of our men are opting for upfront enzalutamide, even if they would be suitable medically for docetaxel.
Fantastic. So, Phil, let's cover off on renal cancer, who'd have thunk a few years ago that there'd be two simultaneous publications for renal cancer at an international meeting? We saw it a few years ago at ASCO, and we've seen it again at ASCO GU this year.
And it might push you over the winning line for the best papers.
Yeah, so this is the second New England Journal publication from ASCO GU. It was the CLEAR study for clear renal cell carcinoma, and it was in first-line metastatic clear cell carcinoma. We know that standard of care in good, intermediate, and poor prognosis are tyrosine kinase inhibitors with either sunitinib or pazopanib, whichever one you believe performs better, and combination immunotherapy with ipilimumab plus nivolumab in the intermediate to poor prognosis. So this trial combined those agents with lenvatinib as a tyrosine kinase inhibitor, specifically against VEGF, plus pembrolizumab, versus lenvatinib with an mTOR inhibitor, everolimus, which we know is used in second and third line, versus sunitinib as the gold standard alone. And the trial, well balanced, rapidly recruited, and really, to cut to the chase, excellent overall survival data. That the median survival for all three arms, because they're all excellent treatments, has not been reached, but the hazard ratio, when you compare the combination of the tyrosine kinase inhibitor and pembrolizumab, the PD-L1 inhibitor, versus that of the standard of care, sunitinib, is 0.66. So quite a significant hazard ratio or reduction in the likelihood of death. That translates to other secondary endpoints, progression-free survival, and the objective response rate, which is quite unique, is that there's 17% or 16.3% of patients had a complete response rate to the combination of targeted therapy and immunotherapy versus single digits for the other arms. And if you look at the combined objective response rate, it was 71% versus 50 versus 30. So significantly higher response rates. Overall survival benefit. Will it challenge combination immunotherapy in the intermediate to poor prognosis? That's another question for a clinical trial. However, we know a lot of patients aren't fit for combination ipilimumab and nivolumab, even though they're poor prognosis. Their ECOG performance status does not allow to deliver that regimen. And this is really an excellent alternative and really will become the standard first-line therapy as another option over that of a tyrosine kinase inhibitor.
I guess that's a wait and see, but there's certainly seems to be a lot of hype about combining the immunotherapy with the TKI. So we've seen nivolumab, cabozantinib, avelumab, axitinib, pembrolizumab, same TKI.
Axitinib, Abe.
We have a bit of a joke about the name pronunciations on this podcast. But the combination seems to be doing something over and above what we've seen.
So you get cellular death and kind of, they're immunomodulators. They're priming the immune system by releasing further tumor antigens, allowing the immunotherapy to work better. That's the hypothesis. It's an adjuvant. They have their own response rate, but when you add immunotherapy to that, it makes the PD-L1 inhibitor, as compared to giving PD-L1 inhibitors alone, a higher response rate. So they do. The science is quite nice.
And Carmel, is it popular in the UK?
We have the option of offering axitinib avelumab, regardless of risk score. That's coming through, although it's a 2-weekly treatment regimen, which is a bit more intensive. I mean, I found this data fascinating as well. Just a reminder to people, these drugs are not easy. Almost 3/4 of patients on the combination lenvatinib pembrolizumab had grade 3 or 4 treatment-related events. I mean, that's a lot. And I guess the other thing I found interesting is that the combination of lenvatinib with everolimus actually performed similarly to sunitinib. So I guess reassuring us that a combination with TKI is the way to go.
Yeah, I've had some experience with the combinations on trial, and there's a lot of patients have dose reductions or breaks or toxicity. So it is not going to be for everybody.
Yeah, but remember, we're comparing it to sunitinib, which is quite difficult to deliver as well.
That's correct. So tell us about, so is sunitinib now in the bin in second line? Tell us about the other abstract we want to do in renal cancer, Phil, which is cabozantinib versus sunitinib.
Yeah, so this is another Lancet paper. So this was actually in papillary renal cell carcinoma, so not in clear cell. So let's make that distinction. So in papillary renal cell carcinoma, there's no standard of care. Not many treatments work. There's no randomized data. Nothing has really been shown to be better over another. Poor response rates, high toxicity. The science behind it is that we know that MET oncogene drives papillary renal cell carcinoma carcinogenesis. And so cabozantinib as a MET inhibitor was trialled versus that of sunitinib as one of the randoms, standard of cares that we use, which is not a bad one, I would say. So a randomized phase 3 trial, and the hazard ratio was 0.6. It was 9 months versus 5.6 months for progression-free survival. And response rates, again, 23% versus 4%. No differences in overall survival at the time of the presentation, but there was a trend to overall survival with more, and I'm sure that will be seen with more mature data. The adverse events, as expected for cabozantinib and sunitinib, no new signals there. And it was clear that this was the first randomized trial to be done in this subtumor type, which occurs in 15% of all renal cell carcinomas, to show a benefit over that of standard anti-cancer therapy for renal cell carcinoma. So I think it is the really first-line therapy. It's a drug that we know is on the PBS for metastatic clear cell carcinoma, so we can access the drug, but can we put it into practice? Not on the PBS, but there are options.
That's right. And so a little plug here for ANZUP, our cooperative group in Australia. They've been great at having series of trials in this rare cancer, so encourage people to send patients for the clinical trials. And into ANZUP's ever-growing network, that's probably the best way to access these drugs for these uncommon renal cancers.
Mind you, I think now those clinical trials, they've been randomised to the inferior arm. We know cabozantinib now is shown to be, this is the winner. So future trials will have this as the comparator.
Phil, let's summarise. So after this meeting, where are we at in renal cancer? So if you could access whatever you liked, what would you do first line? Would it be a TKI-IO combo, or would you go Ipi-Nivo, or?
Yeah, excellent question, Craig. Here I've got my melanoma kind of biases. So I would always give ipilimumab and nivolumab until proven otherwise. And if I believe their performance status and their age, it's too risky with respect to toxicity, then I would give lavatinib and pembrolizumab as the alternate. And if there's contraindications to immunotherapy, then probably pazopanib.
Thanks very much. Okay, Eva, we've got a few quick bites. Do you want to lead off?
Carmel, we're now talking about a paper of N803 in combination with BCG showing promising results in BCG unresponsive, non-muscle invasive bladder cancer. Can you make your buzzer noise, please?
Do we have a buzzer noise?
Yeah, buzz.
Okay, I would like to say my favorite thing about that was that the N803 was a super agonist, but I think it's beautiful. I mean, the combination of that plus BCG was beautiful, complete response rate. So nice data.
So I can just tell you a quick anecdote. I had a patient with lung cancer and brain mets who also had non-muscle invasive bladder cancer, who started on nivolumab for his lung cancer, and the urologist wanted to give him BCG, and I said, let's just wait and see what happens with the nivolumab. And lo and behold, repeat cystoscopy, it had disappeared. So interesting area.
And fantastic, Craig and Carmel and Phil, that we may be able to spare patients who are resistant to BCG from having really very invasive procedures such as cystectomy.
Yeah, really good point, Eva. I think this is an area for further research. There's probably trials going on as we speak, I would say.
And also we need to wait for the trials. There's pembrolizumab trials in this particular subgroup in superficial bladder cancer who are refractory to BCG. So we need to wait the outcome of those clinical trials. But correct, this is an unmet need, refractory BCG and superficial bladder cancer.
Okay, so another new molecule, tivozanib, shows activity in advanced renal cell cancer regardless of prior axitinib treatment.
So I think this trial for me, showed that when the hypothesis in oncology, if you're resistant to one class of agent, you're resistant again. And here, this trial has shown that if you had progression on a VEGF inhibitor, by re-challenging with another VEGF inhibitor, you still have a response. That was the main message. Carmel?
The main message for me is that sorafenib should be in the bin. And actually, I'm sorry, I find it a little bit underwhelming in terms of the response to tivozanib. But yeah, I mean, some patients have slowly progressive disease with kidney cancer as well. So yeah, not much more for me.
What about dose-intensified radiotherapy fails to improve outcomes over standard dose in biochemically recurrent prostate cancer?
This is Eva's favourite topic.
Yeah, Carmel. So I have an opinion about this. It's great to see this kind of data, more radiotherapy, not better in terms of outcome and more toxic. So a very clear answer.
So that'll become standard of practice definitely now.
Well, I don't think anyone should be using the higher dose.
That was a sarcastic comment.
And our last quick bite, Phil, I think we have to be careful how we say this one. Combination belzutifan cabozantinib shows promise in advanced renal cell carcinoma.
Yeah, so this is just a really preliminary trial, which the data is immature, but I think the science is quite delightful here. So we know that in renal cell carcinoma, you have loss of the VHL gene, which leads to activation of HIF2 alpha, and then you get downstream proliferation of VEGF, PDGF alpha, and other oncogenes. So here you have an inhibitor of HIF2 alpha, so the first inhibitor of this oncogenic driver versus a MET inhibitor as in cabozantinib. And the preliminary results are quite promising. So targeting two aspects of the oncogenic pathway in kidney cancer.
Great. So we think this class would have activity in other cancers as well, as this will be specific to renal cancer?
I think it's going to be specific to renal because of the pathogenesis with the VHL gene, loss of VHL gene, leading to increased HIF2 alpha. So I don't think it's going to translate to responses in other tumour types. But I may be wrong.
Thank you very much. So as always, people can click on the links to see more detail.
Can I just ask you, Phil, other VHL cancers, though, it may be active in?
Yeah, it could be. I mean, it'll be trialled. They're quite rare, and hence kidney cancer is rare, but not as rare as others. So they will probably do a basket trial. So as I said, just watch that space.
Okay, look, it's been a fantastic journey, and I actually think you've convinced me that ASCO GU is the winner with all those amazing papers. And it's been great to hear, Phil, your view as you were swinging away on your chair. And Carmel, thank you so much for joining us from the UK. Wonderful to have you back with us in your Australian family.
I never really left.
I'm waiting the day that we can have a coffee together, Carmel. I don't think it's going to happen for a while.
To be honest, I'm just awaiting the day where I can have a proper coffee. I'll take it with anyone.
Eva, that worked really well, don't you think? It was nice having a little forum. We should do that again, another post-meeting.
Yeah, no, it's great fun listening to the opinions of people all over the world and putting the results in context of different countries. So having Carmel's view, she's from New Zealand, she worked in Australia, she's now in the UK, desperate for a coffee. So we should stop complaining. And great to have her perspective.
Yeah. So that's 3 post-meeting specials we've had. We had the GI, lung, GU. So just a shout out to all the people that came on. Thank you. It was a big effort to coordinate it all and put it all together, and for them to often wake up early or stay up late for us to be able to record. So I hope everyone's enjoyed it, and we look forward to doing it again after another major meeting.
Yeah, and thanks to you, Craig, because you did all the hard work coordinating it. But for any listener out there, if you want to be interviewed about a paper or following a conference, then contact us and we'll see what we can do. You too can be as famous as Craig, Hans and Eva. It's been a fantastic Oncology Journal podcast. Join us next time.
I was just going to say, It was a lot of work to put it together, but it's an absolute pleasure just to be able to ask people questions and let them, when they know their stuff, they can just explain it so well. It's actually not a difficult job interviewing these people.
No, it's a great pleasure and privilege, and we hope that their enthusiasm and their analysis and their contextualization really adds something, not just repeating a presentation that everyone can watch, but digesting it, saying how it will alter their practice, and different views on the same data, always fascinating.
Yeah, great. So looking forward to the next episode and not having to rap again.
Yeah, and you're happy that Hans isn't here. Although his pronunciation, yours is bordering on Belgian tonight.
I think I was hypocaffeinemic, actually. All right.
Good eyes.
Bye.
See ya. Bye. It's a very great pleasure to welcome back my very good friend, Professor Michael Hofman, 1F, to Oncology Journal Club podcast, post ASCO GU edition.
Thanks, Eva. Pleasure to be with you.
So once again, you've done some amazing work and had a fantastic oral presentation and a concurrent Lancet publication for your therapy trial. Tell us about that.
So therapy is a investigator-initiated trial comparing Lutetium PSMA 617, which is a novel radioactive compound, to carbazitaxel chemotherapy. This is a trial run by the ANZUP Cancer Trials Group, and we ran it at 11 sites around Australia, and it was really pleasing to report the final results with a co-publication in the Lancet. So in this study, we took men with metastatic castration-resistant prostate cancer who had progressed after docetaxel chemotherapy and mostly after enzalutamide or abiraterone as well. And they were randomized to either Lutetium PSMA 617 or carbazitaxel. And this is an important study because it's the first randomized study of Lutetium PSMA and really the best level evidence we have to date. We screened these men carefully with PSMA and FDG PET-CT, so not all men were suitable. Only men with high PSMA expression, which is around 70% of the patients screened for this trial. And the primary endpoint was met, which was a significant difference in PSA decline of 50% or more, which occurred in 66% of men randomized to Lutetium PSMA compared to 37% of men randomized to carbazitaxel. So that's a 29% absolute improvement in the primary endpoint in the intention to treat analysis. And importantly, we reported a number of secondary endpoints, including progression-free survival, which was delayed with Lutetium PSMA with a hazard ratio of 0.63, which was quite pleasing. So at 12 months, pretty much all the men randomized to carbazitaxel had progressed. Only 3% of men not progressed at 12 months, compared to 19% with Lutetium PSMA, and that was a highly significant difference. We also looked at objective response rate using CT RECIST, and that was 49% compared to 24%. So really quite a large difference in these efficacy endpoints. And sometimes when we have treatments that are more efficacious, they're also more toxic, but here we have the opposite. Lutetium PSMA having less side effects and better patient-reported outcomes. So grade 3 to 4 adverse events, 33% with Lutetium PSMA compared to 54% with carbazitaxel. And what was nice about this study, I think also being an investigator-led study and a cooperative group trial, we embedded lots of patient-reported outcomes, EORTC, QOQ-C30, and also a symptom score, which assessed around 60 common symptoms. And what we saw were significant differences favoring lutetium in a number of domains, such as fatigue, diarrhea, less hair loss, less skin rash, less sore hands and feet, less urinary symptoms, less insomnia. So men, had a better patient experience, less side effects. So it's really pleasing to present these results, and obviously the results now published in the Lancet, so the audience can read a little bit more detail about it online or in the journal.
It's clearly a highly efficacious treatment, and there must be a great desire to bring it much earlier in the patient journey. What current trials are underway?
Yeah, so we have about 5 clinical trials open at Peter Mac at the moment in this domain. I think we still await this treatment really to be available and registered and approved for the therapy-like indications. So that's probably what we're waiting for to start with, and that often takes a few years, but hopefully that'll happen sooner rather than later. But in the clinical trial space, we are moving it earlier and earlier. So we have a trial called the ENZA-P trial, also running at those 11 plus site network across Australia. Patients are being randomized to either enzalutamide or enzalutamide in combination with lutetium PSMA. That's a study run by Louise Emmett in Sydney, also an ANZUP Cancer Trials Group study. And then we have another study that our colleague that we know well, Professor Arun Azad, is running called the Upfront PSMA trial. And this is taking men with newly diagnosed prostate cancer and randomizing them to either lutetium PSMA followed by docetaxel versus docetaxel alone, also running at that network of sites. And then we have a nice trial bringing it really very, very early called the lutectomy trial, where we're giving 1 or 2 doses of lutetium to men with high-risk localized prostate cancer with or without pelvic nodes, and they're having a cycle or 2 of lutetium followed by a surgery. So that's a trial that Professor Declan Murphy is running at our centre. And then we have 2 trials that are actually almost completed, which I probably should have mentioned first. So they'll be the next 2 to be reported. They're both run by Professor Shanine Sandhu and myself. One's called the Prince trial, lutetium in combination with pembrolizumab, just a phase 2 single-arm trial, and another similar trial combining lutetium PSMA with a PARP inhibitor. And this is using a PARP inhibitor as a radiosensitizer. So a whole gamut of trials underway around Australia. Australia is really leading the world in this domain. This treatment is really not available on clinical trials at the moment in any other country. So, we're going to have lots of interesting data to report over the next 4 to 5 years as all these trials read out.
Well, I think that's a tribute to you as one of the main advocates for this compound. In terms of registration, will it be treated as a drug or a device?
The intellectual property for at least the compound used in the trials that we've just mentioned, PSMA 617, is now owned by Novartis. So Novartis are commercializing this. They have conducted their own phase 3 trial in the US and Europe called the Vision trial. And I think we're hoping to see the results of that trial at maybe ASCO in the middle of the year, but I'm not sure. I'm not directly involved in that study, but we're really eagerly awaiting the results because that was an 800 plus patient trial designed for FDA registration, looking at survival as the primary endpoint. So a really critical study, and that will open the door, I think, to Novartis making this commercially available globally. How it's treated from a regulatory perspective will vary from country to country, and this is a really complex area. We could have a whole nother podcast on radiopharmaceuticals in the regulatory environment. So radium-223 is an example of a radiopharmaceutical that was never approved or reimbursed in Australia, sadly, despite being globally available. And in part, that was because of some regulatory hiccups. Is this a device that's given intravenously, or is it a drug? And I think in Australia, you can go through either pathway, but probably what we've learned from the radium story is that for a commercially sponsored drug, the PBS drug pathway is probably the pathway that the Australian government now prefers. So hopefully Novartis will push and get this funded in Australia so that it's really widely available.
Thanks, Michael. Just a question about your therapy study. What role did the FDG PET play?
Yeah, so one of the nice things about this type of treatment with lutetium PSMA is that we can also image the same target using a gallium or a fluoride PET scan, a PSMA PET scan. It's a very similar molecule to a PSMA PET, but we're changing from a positron emitter to a beta emitter for therapy. So this enables us to image the whole body and see whether all sites of tumours express this target. And what we see in men with advanced metastatic prostate cancer, and it's probably no different to any other cancer, is that tumor heterogeneity develops, and not all sites express PSMA. In our trials to date, we've really been very carefully selective and only treating men where there's good PSMA expression at all sites of metastatic disease. And so the FDG allows us to identify sites that are PSMA negative and FDG positive that we can't target. Now, you don't necessarily need an FDG PET to do this. For example, if you've got liver metastases that are FDG positive, PSMA negative, you'll see those on the CT scan. You'll see enlarging liver lesions without PSMA expression. So you don't really need the FDG. But prostate cancer likes metastasizing to bone. And in bone, CT is really not very good. So you don't see the PSMA negative bone metastases on a CT. They're just invisible. They're either in marrow and not seen, or subtly sclerotic. So the FDG is really critical, particularly within bone, at identifying metastases that we can't target.
And what percentage of potential trial participants fell into that category?
So in the therapy trial, 10% fell into a category of low PSMA expression at all sites, and 20% roughly fell into a category of having disease that was highly PSMA positive, but also having disease that was PSMA negative. So all in all, 30% were excluded after FDG PSMA PET CT screening. It's fair to say this will be very different to, let's say, the VISION trial, which is the international registration trial, where FDG was not used. So they are not selecting patients as carefully. We don't know whether there is still a benefit to these patients. There may well be a benefit, particularly if you've got symptomatic pain from metastases, and if those metastases are PSMA positive, you will still presumably get a symptom benefit from treating men. But I think as a smaller phase 2 randomized study, the therapy trial being only 200 patients, 100 patients in each arm, we really wanted to enrich the cohort for men most likely to benefit from this novel therapy. And I think, it's not widely available. There are some access issues, so we ought to be prudent in who we treat at the moment. But I think over time, we'll expand those boundaries and see what is the benefit in a broader population as well.
And do those different categories, is there any correlation with PSA or any other biomarker?
Not really. So PSA and PSMA are different pathways, and I don't think we're seeing really differences in PSA. And in order to be eligible even for the PET screening, you had to have a rising PSA and a PSA over 20. So that's another nuance of the therapy trial. We were really selecting men with very advanced disease. And we did that because we set a PSA response as the primary endpoint. So we wanted to ensure that was relevant for all the men participating.
So, Michael, it's always a pleasure, and you've given us a topic for another podcast, so we'll book you in again. But congratulations. This is groundbreaking work that you and your colleagues at ANZUP have led. I think everyone in Australia is enormously proud of our contribution in this field, and it's a pleasure to have you on the podcast. Thank you very much.
Thanks, Eva. And we should just do a shout out to the people that enabled this study to happen, because this was not really an industry-sponsored trial. It was an investigator-initiated trial. And when it was set up back in 2015, 2016, PSA was not on the global landscape. Most people had not heard of it. And this was funded through a grant from the Prostate Cancer Foundation of Australia. So really, from community donors, together with ANZUP and ANSTO, who are a manufacturer of Lutetium-177, the radioactive substance. They run the nuclear reactor near Lucas Heights in Sydney, kindly provided lutetium for this study. And we did get industry support from Novartis, that now own this asset as well, but a really great collaboration, and Movember as well. So a wonderful investigator-initiated study. And I know you've been involved in cooperative clinical trials groups as well. So it's really a great tribute to all the medical oncology and nuclear medicine investigators. Another great feature of this study was just getting a nuclear medicine and medical oncology co-investigator at all those 11 sites, and they all got working really well together. Monash at your site was great at recruiting patients as well. So we've got this great little network together now, which is enabling all these other studies as well. It's really very satisfying to participate.
I might ask you one more question given that comment, but it is really satisfying doing an IIT. You've already told us about the differences between your study and the one that the commercial partner who now owns this has chosen to do. How do you bring this all together to be as successful as you've been?
Yeah, I think it needs a bit of luck, a bit of vision, goodwill of investigators working together. I think we do need groups like ANZUP for prostate cancer and other groups for other tumour streams to bring everyone together. Without these cooperative research groups, it's really difficult to execute these trials. We had NH&MRC CTC as the coordinating centre, and they did an absolutely stellar job with data collection. So you need all these elements. It's a little bit like a winning sports team. There's no single element. It needs a really big team effort. And for this study, actually another unique feature, just to throw it out there, was that the radiopharmaceuticals were made in each of these 11 hospitals, which is a unique feature. So the lutetium was shipped from ANSTO and the PSMA 617 now from Novartis, and it was manufactured in hospital radiopharmacies and then given to patients. So we had a lot of quality control behind the scenes happening, really a remarkable effort to pull this off.
So, Michael, in all seriousness, you gave a very lovely interview then, highly professional, but boring. And I hear your colleague, Declan Murphy, just has gone viral with his presentation. Can you tell us about that?
Declan did a very wild presentation about PSMA PET. There was a sort of plenary educational session at ASCO GU, and he hired a Hollywood studio to put together a Wild West themed talk, and it's got backdrops. It's not like a usual Zoom talk with a little face in the top right. You see Declan suited out a bit like a newsreader with a very exciting background changing. So it's a must watch. You must put a link to the talk with your podcast because it is available on YouTube. It's highly entertaining. I think it goes for about 12 minutes, but it is really an excellent summary of state of play of PSMA PET and some of the challenges with PSMA PET. And the only bad thing about it is Declan is wearing a suit and he didn't put his cowboy hat on.
Yes, well, he's certainly raising the bar for the poor old Zoom presentations. So he might have sparked a turf war on that. We'll have to watch out. But hiring a Hollywood studio, maybe we need a celebrity next time on the show.
Well, there was a big Aussie show at ASCO GU. There were a lot of presentations from Australians. Quite remarkable. Many, many.
Fantastic. Thanks again, Michael.
Thanks, Eva.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.